Hello, hello, hello,
Hello.
hello.
Sir, good morning, sir.
Good morning, sir. Am I audible, sir?
Yes, sir, very much.
So, good morning, everybody. And at the outset, I would convey my thanks and regards to the entire organizing team of midterm CME AOI Bhubaneswar, AOI Odisha, with a special thanks to our President, Dr. Bishwanath Das, Secretary, Dr. Khageshwar Rawat, and the most dynamic organizing secretary, Dr. Anil Kumar Das, for giving me this opportunity to interact with you all. Thank you once again, everybody, for making me part of this event. Thank you so much.
Thank you so much, sir. Rather, we are also thankful to you, sir, because in spite of all the busy schedule, you spare a day for us. So that is why we are also very much thankful to you. We are eagerly waiting for the academic events that you will conduct over there.
Thank you, sir. Boss,
Thank
ये
you,
connect
sir.
करना.
Thanks a lot, sir. Thanks a lot, sir. Myself, Anil, sir.
Thank you.
Okay.
Thank you all once again.
Okay, sir. You carry on with your life, sir.
So, as planned, we have a couple of surgeries today, which will go on till 2:30 p.m. as the time slot I have. So, the cases I am going to begin with the basics, with the functional endoscopic sinus surgery. I hope you are seeing some scan on screen. अंदर
Yes,
कर
sir.
दिया.
CCT
So,
scan is on the screen.
yes. So, this patient is a young male having classical symptoms of chronic rhinosinusitis with typical of sneezing, nasal obstruction, intermittent headache, nasal discharge, and so many other complaints which goes in favor of, CRS. And this
It
has
is
been
chronic
persistent for months together.
rhinosinusitis or
Yes,
allergic rhinosinusitis, sir. It
this
is.
is chronic rhinosinusitis
Okay.
with classical complaints of nasal obstruction, intermittent headache, sneezing also. This particular patient has nasal discharge, and all have been persisting for months together. Now, we have done endoscopy showing multiple polyps with interspersed with some allergic mucin suggestive of fungal disease. Classical picture of allergic fungal rhinosinusitis on endoscopic as well. And this final CT scan to substantiate our diagnosis as well as giving fine details we have. This is the CT scan of this particular patient. On our DICOM, when we order CT scan, we always mention to get CT scan giving you maximal anatomical detail. It goes by
Your voice in between. Can you repeat it, please?
yes. So this particular scan is 0.4 mm sliced.
Okay.
Fine sectioning you can see here at the lower left corner, 0.4 mm sections. So it doesn't miss anything important
Okay.
as far as anatomy is concerned in the paranasal sinus labyrinth. So here what we see with every movement, it goes by 0.4 mm. Now, this can be viewed in both bone window and soft tissue window settings as well. See, I converted to window setting, giving more and more bony details as well. See this? More and more bony details. If I
Yes.
convert to soft tissue window settings, see now, look into the orbit and surroundings, more and more soft tissue details now. This is how you can, extract more and more information from your CT scan. A snapshot, a printout of a CT scan doesn't carry that much of significance. Reason being, it gives limited information. We want finest of the anatomical details in the dynamic plane, that too multiplanar. And that is best served by these DICOM images. So DICOM in this software gives you extremes of all possible details of the area you have scanned. And here the paranasal sinuses, we need each and every possible detail. The reason being, the safety margin in sinus surgery is very less. The orbit, skull base, carotid artery, optic nerve, all are in vicinity. The threshold is very low. Even a sub-millimetric, loss of orientation can lead to hazardous effect, can be fatal even. We must be well versed thoroughly with the anatomy of the particular case we are going to operate, and that is best served by a good CT scan. It all depends upon, the onus is on the surgeon to order what kind of scan, you prescribe. If you write a CT PNS, the radiologist will take one coronal section, 5 image, one printout, and it's over. CT PNS is over. But that is not adequate. That doesn't suffice your need. That doesn't give perfect anatomical details. And for that, you need to ask 0.5 sections or so in DICOM format. Then you can reconstruct this software in all possible plane. And it's an amazing tool, to discuss the radiology, to discuss the anatomy, everything. Now, what you see in this image, see this. We see heterogeneous densities in the paranasal sinuses. If you notice, heterogeneous densities.
Yes,
Yes,
yes.
sir.
This
Fungal.
heterogeneous densities, when a more and more dominant unilateral disease in the young patient, is classically suggestive of allergic fungal rhinosinusitis. When you have an endoscopic finding of polyps with mucin interspread in amongst the polyps, this is
Okay.
good enough to establish a diagnosis on the basis of endoscopy and clinical details and CT scan. So this is how Bent and Kuhn described, laid down the criteria that how this is diagnosed. Classic nasal polyposis, this heterogeneous densities, classical fungal mucin. If you get the, allergic testing done, this is type 1 hypersensitivity to the fungal material and fungal positive in the stains, in the smears. So this is all, suggestive of this classic variant, very important, very common variant of CRS, that is allergic fungal sinusitis. CRS now has been well studied. It is an inflammatory disease. It has variety of endotypes. Every endotype has a different underlying pathophysiological process, different clinical course, different, preferred mode of treatment, different post-operative treatment, and different treatment for the adjuvant, comorbidities. This allergic fungal sinusitis is classically because of the person who is allergic to fungal material. Fungus is ubiquitous in the air. Whenever we inhale, fungus goes into the nose. But by our mucociliary activity, by our strong nasal immunity, it is expelled into the nasopharynx and then to the gut. But those who are allergic to fungus, the moment fungus is trapped in the nose, the allergic reaction starts. The eosinophilic activity starts. And if this fungus happens to get trapped into one of the paranasal sinuses, the, the resultant eosinophilic activity around the fungus secretes this classical, mucin, which is composed of degraded eosinophils, fungal material in the core, and a lot of allergic, material. And that leads to blockage of the paranasal sinus outflow. That starts a vicious cycle of obstruction to the drainage, obstruction to the aeration, and ultimately a vicious cycle starts and involve more and more paranasal sinuses to give this classical clinical picture of AFRS. So the classical pathophysiology underneath is allergic to fungal material. Allergy is an antigen antibody reaction which is beyond your control in spite of all measures. So here the treatment, like for any allergic pathology, is steroid. Steroid is the mainstay of treatment. But for such fungal material which has occupied all paranasal sinuses, see the expansile sinuses everywhere, ballooning out because of the material trapped inside, no aeration, no drainage, and the antigen, which is fungus, which is trapped inside. You need to remove all this antigen and all this material to establish the ventilation and drainage. And that's how establishing ventilation and drainage, removal of all this inflammatory load is the key basis to carry out endoscopic sinus surgery. That's how the role of endoscopic sinus surgery has a established role in this particular pathology, to establish the ventilation drainage and to remove all this fungal and the eosinophilic material, to remove this inflammatory load. Added on to this, since steroid is the mainstay of treatment, opening all these paranasal sinuses in this particular pathology, wide opening is required so that you can, push topical steroids into the depth of the paranasal sinuses, where the mucosa is diseased, where the site of pathology is the mucosa within the paranasal sinuses. You can penetrate topical steroids deep into the sinuses, and that is how is the basis of, uh, the endoscopic sinus surgery in this particular pathology. So, three-prong approach by the sinus surgery: establishing ventilation and drainage, removing inflammatory load, and allowing the topicals to penetrate deep into the sinuses to prevent future so-called recurrence, future pathology to regrow, and all this is required under lifetime surveillance. Though post-operative immunotherapy to the allergen and all that have been part of the adjuvant therapy, but antifungals have no role at all. Since this fungal disease doesn't penetrate the paranasal sinuses, there is no role of antifungals. There are variety of fungal diseases like chronic invasive aspergillosis, acute fulminating fungal disease like mucormycosis. Those are invasive diseases where the antifungals have core role. The core treatment is medical. Surgery is just carried out to remove the necrotic disease where the antifungal do not penetrate. For chronic invasive aspergillosis, voriconazole is the drug of choice. For acute fulminant, amphotericin B the drug of choice. For this AFRS, steroid is the drug of choice. Antifungals have no role since fungal doesn't penetrate the paranasal sinuses. So there is no point in giving antifungals at any point of time, pre or post op, except in some extreme situations like diabetic where you can't give steroids as a rescue medication. Pre-operatively, to buy time by means of reducing the fungal load if there are compressive symptoms, visual symptoms like those. So except those extreme situations, antifungals have no role. So surgery has a main role, and for surgery, we need to know the anatomical details as it is in the paranasal sinuses are so strategically situated in close proximity to the vital structures. So we need to have three-dimensional anatomical details for which the role of CT scan is phenomenal, pivotal, and we need to know CT scan ourselves as well to read, to know the anatomical details. Radiologists have never been able to give details because of the time constraint, because of, so many things. But we need to know and, extract the maximal anatomical information. So, in brief, the case is ready. In brief, what I can show you, this particular patient, this is coronal images. Maximum information you can easily gain through the coronal section because it gives information in the same plane which is easier to understand, the same plane in which we operate. So you can grasp easily. For more anatomical details, you can refer to the axial and sagittal, which are important for certain areas. Sagittal, like for frontal sinus, I'll refer to it. So everything is important. Now see, if we come from anterior to posterior, now every movement is 0.4 mm. See this, I am going, this is frontal bone. These are two frontal sinuses, opacified, the left completely opacified, right is partially. This is the nasal bone, frontonasal process. See the nasal bone below, completely opacified, going behind, it forms the beak. Now you go behind the nasal bone is the beak, and see beak forms the floor of the frontal sinus. As you go behind, where the beak goes away, see this now, this is the frontal recess, which is the drainage of the frontal sinus. Message. This is the drainage of the frontal sinus. That means to posterior. See anteriorly was the beak, and where the beak ends behind is the frontal sinus drainage pathway. This is important to understand. Beak is one anatomy which is always present in spite of the multiple revisions, unless you have done draft earlier, it is always present. So refer to the beak to look for the frontal sinus easily. This is one of the best landmarks surgically to open up the frontal sinus. Let's see in the sagittal plane what I'm trying to say. See this. This is the beak. This is the beak. Here is the beak. Now, see the sagittal plane. See the sagittal plane. This is beak. This is biggest obstacle to enter into the frontal sinus. See this? When you come
Yes.
endoscopically from here to enter into the frontal sinus, which is so anterosuperiorly situated at some definite angle, and it makes life of the surgeon difficult to visualize from inside. And you really need most of the time angle scope, 70 degrees, the best scope for visualizing inside the frontal. The biggest obstacle is this beak. See this beak? Now, if we come from anterior, this is the beak. See this? Where the beak ends, if I go from here, where the beak ends is the frontal sinus outflow. So, in our surgery, we'll corroborate the same finding. We corroborate the same finding surgically as well. See this? You follow the beak, follow the beak, follow the beak. Where the beak ends is the beginning of the frontal sinus drainage pathway. Here on the left side, what we see is some complication. See this? Here is the beak which ends here, and behind is a big cell going up. Can you see this?
Yes, sir.
There is a big cell going up within the frontal sinus. See this? The frontal drainage pathway, which is from here to the skull base.
Yeah.
And this is narrowed by this big cell attached behind onto the skull base. This is frontobular cell.
Yeah.
So the frontal, ultimately because of this cell, the frontal drainage pathway is narrowed to this. Can you see this?
Yes, yes.
This is narrowed to this. So in order to widen, to establish the drainage pathway properly, we need to remove this cell completely. Since
Yeah.
it's attached to the skull base, we need to flush this cell with the skull base to widen this pathway. Widen this pathway completely. Can you see?
Yes.
Now, look this cell in all planes. Let me show you first in the coronal. See, in coronal plane, if I am going from anterior to posterior, anterior to posterior, anterior to posterior, can you see some cell coming in the left frontal sinus up?
Yes, yes.
Looks like isolated cell, but coming far behind. There are group of cells which are attached to the anterior wall. Those are frontal cells. They are attached to the anterior wall, and for their treatment is go behind them, those cells, and fracture them out anteriorly. But see, this cell is coming far behind. See this far behind, and it attached to the posterior wall. We have seen. You cannot afford to go behind. You have to open up this cell from anteriorly. Open up this cell from anteriorly. See this? You have
Yeah.
to open up this cell anteriorly, and flush till posterior limit. You
Okay.
cannot afford to go behind, otherwise you will end up damaging the skull base.
Exactly.
This is how the CT scan has to be read and extract the desired information. This is not possible with the printouts, with the static images. You need to have dynamic three-dimensional images to reach and map the entire cell right from its attachment to the extent where it is going into. अभी देखूंगा थोड़ी ये बिठा बोल ड्रेसिंग हटा के रख. So this is how the frontal sinus pathology in this particular patient on the left side, which I am going to demonstrate. Say one side I am going to demonstrate, and this is the left side, which is important pathology, which is I am going to demonstrate. So that is the frontal recess. Now, as you go behind, see, as the frontal recess ends, the cribriform plate starts. So cribriform plate is just behind the frontal outflow. It's behind the frontal outflow. बोलना मैसेज करें. And see, there is a lot of disease in the ethmoidal labyrinth. See, this is cribriform plate going behind. See now the cribriform plate behind. At this point, at the posterior most part of the anterethmoidal roof, is the beaking of the orbit here, which leads to anterethmoidal artery piercing the lateral lamella of the cribriform. This is where there is a confluence of medial rectus and superior oblique. So it is far behind. See the cribriform plate here. And as we go behind, the anterior ethmoidal roof disappears and the posterior ethmoidal roof, flat, thick posterior ethmoidal roof appears. That means anterior ethmoidal artery passes through the posterior most part of the anterior ethmoidal roof. That means while working in the frontal recess, the anterior ethmoidal artery is far off. It is in the running through the posterior most part of the anterior ethmoidal roof. You don't need to fear about the anterior ethmoidal artery. Don't get terrified while walking at the frontal recess with the anterior ethmoidal artery. It is far off. Maxillary sinus, full opacified. See the post-ethmoidal cell, large, bigger cells, completely opacified. And as you go behind, see this. This is the sphenoid sinus. This is ballooning of sphenoid sinus because of the fungal mass, fungal disease, which is expanded frontal sinus. See, which has deflected the sphenoid sinus, deflected the intersinus septum. And see the entire frontal sinus. This is intersinal septum, which is deflected to the opposite side. This is left sphenoid sinus with lateral recess on the left side. And this is right sphenoid lateral recess with hardly any small right sphenoid sinus on the opposite side. See this is the midline and how the intersphenoid septum has pushed far laterally. And such laterally pushed septation should be gently removed. See where it is going? Towards the carotid artery. Here it is expansion of the sphenoid sinus. See what it is? This is impression of the optic now. And very close to it, it is dehiscent as well. So in expanded sphenoid sinus, you have to be ultra careful about the carotid artery, optic nerve, all these things. In all these expanded sphenoid sinuses, this is right sphenoid lateral recess, right sphenoid sinus, very small, and this is all left sphenoid. It looks like the entire sphenoid is replaced by the left one. So these are the positive findings I touched upon in this particular case. Anything you want me to show in radiology, sir?
No. Already. Hello, sir.
Hello?
Yes, sir. The sphenopalatine foramen was visible in the last section, approx.
Yes, sphenopalatine foramen, if you want to see, I will show intraoperatively as well. Now see here. This is your maxillary sinus.
Yes, sir.
I am going behind it. See this behind, keep an eye behind. Now where it is ending. See, this is sphenopalatine foramen.
Yes.
This is orbital apex. This is inferior orbital fissure. This is infratemporal fossa. This is pterygopalatine fossa. This is sphenopalatine foramen, and this is the posterior most part of the nasal cavity. So that is most posteriorly the site of sphenopalatine foramen. And if you want to see in all planes, I can show you in all planes. See this? This is sphenopalatine foramen in all planes.
Yes, sir.
See in the axial. Can you see the foramen level? This is posterior wall of the maxillary sinus. This is the infratemporal fossa. This is pterygopalatine fossa.
Yes, sir.
And at the medial end of the pterygopalatine fossa is the sphenopalatine foramen. Here in the sagittal plane, see the classic anatomy. This is sphenopalatine foramen. See this? Here from here, this is pterygopalatine fossa level. Here is the greater palatine canal leading to the greater palatine neurovascular bundle. This is orbital apex, and this is the inferior orbital fissure leading to the orbital apex.
Yes, sir.
So that is classical picture of the, you know, sphenopalatine foramen.
Yes, sir.
Any other thing you want me to show?
The median and foramen rotundum were also visible in the posterior.
Pardon?
The median canal and the foramen rotundum.
Okay, great question. See this. See this at this level of the pterygoid bone. See lateral recess?
Yes, sir.
On the medial end of the lateral recess, in line with the medial pterygoid plane. See this. This is median canal.
Yes, sir.
Both sides in line of the medial pterygoid plane is the medial canal, median canal. And laterally here, across the lateral recess, median canal, lateral recess, across the lateral recess, this is V2. That is foramen rotundum carrying the maxillary nerve.
So median is median.
Pardon? This is median nerve. This is V2.
Yes, sir.
So more and more lateral recess is pneumatized, more and more, see these nerve prominent. More this pterygoid bone is thicker, the less will be the, thickness of the canal. So here, see the more and more pneumatized, less is the thickness. And see many times in the large pneumatized lateral recess, you may find these nerves to be dehiscent as well.
Yes, sir. Was there any, sir, dehiscence of the optic canal, sir?
If optic canal is dehiscent, you are not supposed to do anything.
Yes, sir.
First principle in sphenoid sinus surgery is never use any sharp instrument inside the sphenoid sinuses. Even if there is full of fungus, this patient particularly is full of fungus, we will suck out the fungus, we will flush out, but we will never use any sharp instrument within the sphenoid. In all these expanded sphenoids, it is not uncommon to see optic, carotid, dura, everything dehiscent.
Yes, sir.
So we can continue this discussion during live surgery as well.
Yes, sir. We can carry
Because
on
our
with
time
surgery,
is limited till 2:30 and we have to show JNA case as well after this.
Yes, sir. We can carry on with the surgery, sir.
So please feel free to interrupt me any point of time during surgery as well for any questions, any query, any suggestions. Our case is ready and in couple of minutes we'll be with you with a endoscopic picture.
Okay, sir. Hello. Hello, Operation Theatre. Hello.
Yes, sir.
So we are not getting any picture. The case has been started or not?
Yeah, no,
Hello?
sir is washing. Sir is, yes.
Hello?
Yes, sir.
Can you hear me?
Yes, sir. Very much.
Are you
But
getting the picture?
picture is not there on our screen.
Just wait for a minute. Let me
Yes.
know when picture comes.
Yes, now we are getting it. Yeah.
So this is left. Let me do white balance first. Okay. This is left nasal cavity.
Okay, sir. Yeah.
This is
Deep sinus
unprepared.
secretions. Yeah.
Yeah, this is unprepared. What you see
The
are
polyp.
multiple polyps.
Yeah.
This case has been prepared with a course of antibiotic and steroid for last couple of days to reduce the inflammation. Now, as a part of intraoperative preparation, the first thing I am going to do is the topical decongestion. See, the preparation has immense role in reducing the overall bleeding
Okay. What
by
is the
means of
solution? What solution is used to decongestion?
optimizing the field. We tend to reduce the overall bleeding.
Okay.
A pre-operative course of steroid reduce the inflammation and the overall vascularity, vasodilation, everything is improved and reduces the overall bleeding.
How long would you prefer to give steroids, sir?
5 to 7 days, sometimes 10 days, according to the case you have scheduled.
What would be the strength of the steroids, sir?
So we start with 1 milligram per kg prednisolone in tapering doses.
Within 10 days, sir.
Yeah.
And what antibiotics do you prefer and how long?
Antibiotics, if there is any secondary infection, then only.
If it is there, which antibiotic would you
And
prefer?
step 4 is directed. You can give initially amoxiclav, or if you have a culture report, you can give linezolid, you can give clindamycin, but should be mostly directed towards staph aureus. Can you see this?
Right.
Allergic mucin, allergic mucin.
Yes, sir, we can.
See, after even the first decongestion, the nasal cavity has opened up. Earlier, there was hardly any space. See now? So this marrow cell, see, all this is mucin. This is classical of allergic fungal rhinosinusitis. This is all allergic mucin. This is sticky mucin. See this?
Yes, sir.
Yeah. See, there's multiple polyps.
Yeah.
Even what I can see as a part of anatomy, only inferior turbinate, inferior meatus. This looks like middle turbinate medially here,
Yeah.
which is compressed because of the polyp in the middle meatus, which is full of polyps. So what I am using, these marrow cell pieces soaked in saline and adrenaline, being used as decongestant. See this? Just apply over the mucosa to decongest the mucosa, decongest the capillaries basically. Here the main source of bleeding is capillaries. The main source of bleeding is capillaries, and this is how you decongest the capillaries. And open up more and more space. So this will further decongest the capillary, further improvise the field. You can ask your anesthesiologist to reduce the heart rate, to reduce the cardiac output. Our preferred heart rate is around 60. See on the screen 62, 61. Can you?
Yes, sir.
BP is 120, 119/85. So normotensive, no hypotensive anesthesia. The bleed is, since bleeding is mainly from the capillaries, the reduced cardiac output is the key in minimizing the blood loss. in improvising the surgical field. So if your surgical field is good, since this is a surgery of landmarks, you'll be able to identify the landmarks more clearly and the chances of complications can be minimized. So this is after the initial decongestion. What I'm using this, see this is polyp. So I'm using the shaver micro debrider. To remove all these luminal polyps. See the fungus. See, all this is luminal polyps which I debrided. And how it has distorted the anatomy. See, this is ballooning of the maxillary sinus content. This is the uncinate process which is distorted here. That is the fungal material. See this? This is your middle meter and this is your turbinate, which is also distorted. Looks like concha bullosa as well. So this is the initial picture after. See some polyp medial to the middle turbinate as well. See the polyp medial to the middle turbinate. This is one indication for partial resection of the middle turbinate, particularly the inferior part, for the aeration of the area medial to the middle turbinate, to allow the steroid reaching to the olfactory cleft, because there are lots of polyps in this region.
Sir,
And
is
see
that
this
arising
again.
from posterior ethmoid?
Pardon? These polyps are coming from behind, yes, postethmoids. So after every step, you can decongest further to improve your field. This application of topical need not to be placed for long. This simply to apply over the mucosal surface. Opposite side, there is a slight DNS as well. See the DNS on the opposite side.
It was evident in a CT scan. It was clearly
Pardon?
visible. In the CT scan, it was clearly visible. DNS to right.
Yes. So this is how the preparation in between. This is so vital, so important in optimizing the field. The goal is to minimize the bleeding so you can visualize at every point of time. Intermittent irrigation as well. Now, since because of the polyps, because of the massive disease, everything is distorted. This is your distorted uncinate process. See the disease which is ballooning anterior to it. This is your nasolacrimal duct prominence anterior to it. This is hiatus semilunaris. See this?
Yes, sir.
And there is fungal disease which is coming out of it, ballooning out of it. See this? So what I will do, I will use a reverse biting and create a mega middle meatal enterostomy here. Reverse biting, engage, bite through the uncinate and come anteriorly direct little inferiorly to away from the nasolacrimal system. See this. This is your middle meatus. This is your interior of the maxillary sinus now. Yes. See the interior of the maxillary sinus now?
Yes, yes.
2/3. What I will do, I will enlarge this middle meatal enterostomy.
So you are using a straight tricot blade or the
2/3. Pardon?
what is the blade you are using? The micro debrider blade,
Yeah, red 40.
grade 40. Okay.
See, I am enlarging this middle meatal enterostomy till behind, till close to the posterior wall, because there is a massive disease in the maxillary sinus, and we really need thorough post-operative irrigation later on. See this, widening the middle meatus, widening the middle meatal enterostomy. This is the middle meatal enterostomy, and some polyps is in it. Can you see?
Yeah.
Let me first decongest again. Fix it there. Upper there, okay. Wash. See some edematous mucosa within the maxillary sinus, which is to be respected, not to be radically removed. As once the ventilation drainage is established, once this fungal antigen is removed, it settles down. We have to respect and preserve the mucosa all the time. Wash. See the mega middle meatal enterostomy.
Yes, yes.
I will flush out and later on see with the 70°.
Sir, do you do any specific investigation if you suspect fungal sinusitis before taking the patient for surgery?
Yeah. Radiology itself gives a lot of information.
Yes, sir.
If there is invasive disease, you can find on radiology. If anything suspicious, then you have to get MRI done. Suspicious means beyond CRS. If you suspect some tumor or any other abnormal pathology, then you need to get MRI done.
No, sir. Like for fungal sinusitis itself, any other investigation is it?
Not really, not really. Unless you suspect the invasive disease. Invasive means MRI is must.
MRI. Right.
See, I am mopping away. See, there is fungal disease. Still some minimal fungus. Wash thoroughly, remove each and every bit of fungus. Fungus in this particular variant is a antigen.
Okay.
You have to remove it thoroughly. Flush it. I know. See? Flush thoroughly. See the middle metal enterostomy now? Much better.
Yes.
And now I will leave a piece of marrow cell and later on we'll see with the 70 degree. I will leave this marrow cell here in the middle meatus, in the maxillary sinus. And we'll come back later with a 70 degree. Come. Hmm? Again, mop, wash, irrigate, improve the field, reorient yourself, and then come back again. See, this is middle metal enterostomy, where I have left a marrow cell. So the field is overall good. Now I'll take care of the upper part of the uncinate. See, this is the upper part of the uncinate. Just go behind it. See, pakadna. Go behind it. Go behind it and fracture anteriorly. Anterior fracture is safest. Like this. This is a very important part of the surgery. As the moment we remove it, we are close to the lateral wall of our entire corridor. That is medial wall of the orbit. That is. See the medial wall of the orbit there? This is medial wall of the orbit. This is medial wall of the orbit here, lamina peperacea. The moment you remove the upper part of uncinate, you should be able to see the lamina peperacea, your medial wall of the orbit, your lateral wall of the entire dissection. See, this is the uppermost part of the uncinate I am removing. So you reach your lateral limit of the surgery at this point only. See, I am opening up the axilla with red 40 to maximum. Opening of the axilla to the maximum. To the maximum you can. Like this. Your rest of the work will be much easier after that. Now below is your bulla, which is most of the time because of the massive disease gets compressed. And above here, I'll go for the frontal recess. And the simplest landmark I'm going to share with you is going to be your beak. See this? The upper part of the uncinate been removed. Let me remove all pecs. Let me remove all pecs. See the maxillary sinus, much better. See middle metal and trust me. This I purposely made wide because of the fungal disease. I want more steroid to penetrate freely inside. I want a longer endoscopic follow-up, lifetime surveillance, you can say, which you can do with an endoscope in your OPD through the sinus openings. Now, so what we have done so far we have done a middle metal enterostomy. We have done a removal of the upper part of the uncinate. Now I am changing to 70 degree. Now I am changing to 70 degree to look up. See this? Looking up with a 70 degree. Hmm. See the interior of the maxillary sinus with 70 degree now. Can you see? Hello? Hello? क्या करते हैं यार?
Good.
Hello?
Yes, sir, we can hear you.
Okay. Could you see the interior of the maxillary sinus with 70 degree?
Yeah.
And now with 70 degree, before doing anything else, I would go up and look into the frontal sinus. See the axilla, how much I have opened the axilla.
Yes.
See this with a 70 degree. At one side, my limit is my turbinate. See this turbinate?
Yes.
Middle turbinate, this is one limit. Laterally, it's going to be the lamina pepraceae. You can see your limit.
Yes.
If you cross your lateral limit, you will be in the orbit. If you cross your medial limit, you will be in the skull base. And if you stay in between these two limits, is the area which we are intended to go further. See this. This is your beak. 120. This is your beak here, where my section is. Stay in between the lateral limit, medial limit, and this beak is the thickest of the bones. See this. This beak is the thickest of the bones, as I shown you on CT scan. See this beak? If you follow the beak and go behind, you will go nowhere but to
Frontal sinus.
frontal sinus. See this. I'm widening this space to show you. In the simplest manner, how one can reach the frontal sinus. See, removing the polyps in this region. See the beak above, the thick bone. See the thick bone above?
Yes.
Where this thick bone ends, See where this thick bone ends is the frontal sinus. See carefully. Fantastic anatomy. This is the thick bone of the beak. Can you see?
Yes.
Yes.
Yeah.
Now I am following this and going behind, going behind, going behind. Can you see the edge of the bone? Edge of the bone, where this bone is ending, where my instrument
Yes.
is.
Yes.
Now this is your frontal. See the edge of the bone behind?
Yes.
This is my frontal sinus where my instrument has gone. See this?
Yes. Yes.
Would you see or not? This is your frontal sinus.
Yes. Yes. Yes.
Let me show you again. Let me clear it and show you. This is the simplest version one can think of. See this beak. That is a beak. Let me decongest and show you once again. In the simplest way, you know, this is your beak, beak, this is going, this is ending going into the frontal.
Yes, sir. So nice.
See, this is your beak,
Yeah.
this is your beak from here onwards. From the axilla, this is beak, going, behind. Where it ends is the frontal.
Oh, so nice.
This is frontal. This is where my instrument has gone deep.
Yeah.
Now let me remove this little bit of the tissue anteriorly to widen. So I'll be using reverse blade, adenoid blade, red 40 blade,
Okay.
which becomes the front facing in 70 degrees. See this?
Okay.
And remove this posterior tissue to widen the space. Now see where the frontal is up there. But this opening is narrowed by what? I showed you on CT scan.
Yes, sir. There
Narrow
is a,
opening,
yeah.
frontobular cell. See, this is your
Frontobular cell, there
frontobular
is a
cell.
frontobular.
This is your frontobular cell. This is your frontobular cell, and just anterior to that is the frontal sinus. See there up?
Only
this is your,
is in, sir. No. Yeah. 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 Now it is visible. Yeah.
so let me remove a part of the beak to show you better.
Exactly. Exactly.
This beak which is overhanging,
Yeah.
I'll remove a part of it with a special instrument that is called articulated punch.
Punch.
Yeah.
You can use a drill also, sir, over there.
No, I'm just punching out a bit of overhang bone.
Okay.
See this overhang bone?
Yeah.
Section look. See this? Yeah. See the overhang bone above?
Yes,
This
sir.
bone.
Yes, sir.
Yeah. So what I will do,
What is the punch you are using, sir?
this is articulated punch. See this punch?
It's not the same spanner punch. It is something else.
Yeah, it has many articulations. That's not a straight punch.
Okay.
See what I've done? I have bitten off this overhang bones
Yeah.
to see into the sinus. Can you see this?
Yes, sir.
Now what is there behind which has narrowed the sinus? Is this cell behind,
Yeah.
this frontobular cell which we had seen on CT scan.
Yes, sir.
Unless I don't remove this cell, this opening would be very narrow.
Yeah.
See this frontal sinus above?
Yes.
But the opening is narrow. So what I will do now, see this is the cell.
Yeah.
And see the fungal material within the cell. See this is all fungus.
Yes, yes.
So you're supposed to break the cell from anterior to posterior, no?
Yes. You
Okay.
cannot afford to go behind this cell.
Yeah.
The posterior wall is formed by skull base.
Skull base, exactly. Yeah.
See this cell from inside.
Yes, it is seen.
So now I will grasp this cell like this. And more and more. And up. Here's this cell. Here's this part of the cell.
Yeah.
Here's this, and behind that is frontal sinus.
Yes. Now it is clear.
This is the remnant of the cell wall.
Yeah.
Dome of the cell.
Yeah.
And see the huge frontal sinus behind. This cell was obstructing. And see, this is the frontal sinus and a lot of fungus inside.
Yes.
So I will flush it now. What an amazing finding. See the frontal sinus? See the beak. Where the beak ending is the frontal. Bottom line, if you find the beak, you cannot miss the frontal. See now I'm in the frontal.
Yes, yes.
Hydromonga. See the huge frontal. Section. See huge frontal in the depth, huge fungus in the depth of the frontal sinus.
Yes,
Yes.
yes, sir.
And I will be using now hydrodebrider to flush it out. Hydrodebrider is an amazing tool which uses a jet of water. I will show you. See, I will flush the lateral limit with the lamina. Yes. See the amount of fungus there within? Now what I'm using is this hydrodebrider. I can rotate it 360 degree. See this 360 degree, I can rotate this
Okay.
like this and use a water jet and you will see all fungus getting flushed out.
So it is the same debrider with a different blade, or it's altogether different
It's a
instrument?
different tool, different tool.
Different tool. Okay.
See now, I have
Like
angulated it
malleable.
with it. See, I have angulated it within the frontal and now see the water jet start. See the fungus coming. See the amount of jet. See the fungus getting dislodged and coming out.
Yes, sir. But suppose say we don't have this equipment, sir.
Let me
We
show. See
simply-
this from the corner. No, brother. See how this fungus has been dislodged.
So would it be okay to jet flow with a curved suction only?
Pardon?
Curved suction cannula, we can put there and do a just forceful washing. Will do the same thing.
Yeah, you do the same thing, but this is a jet which goes all around. And this lodge is बड़ा वाला jet है। सामने वाला मोबाइल नहीं जाएगा ये। बोलो सामने वाला। Give me a section. ये दे दे लंबा। See the fungus inside. It has been very well dislodged. See the amount of fungus coming.
Yes, sir.
Sometimes it becomes so difficult to remove this fungus, and this hydrodebrider really helps to dislodge.
But how do you confirm that lateral recess of the frontal?
Yes,
side?
we will. Hmm.
Yes, still some amount of fungus visible.
Yes.
So you are going there inside with the same 70-degree scope now.
Okay. सब दे यार सामने वाला मंगाया थी। See, now the entire fungus has been out. Can you see?
Yes, sir. Yes, sir.
Hydrodebrider once again. Hydrodebrider will dislodge even the minor particles spread over the mucosa. See this? High pressure jet.
Yes, sir. Yes, sir.
Patla. And the entire area getting more and more cleaner. पतला दे यार बोला ना तेरे को पावरफुल हो रखा है ये गिर गया Yes, much better. What? Hello? Now, under vision, we can wash and see. Let me just clean that. Incorrect. See, in every nook and corner, still some amount is coming. See that?
Yes, sir.
Sir, in this case, can we try with mopping with a Merosil?
Yes, you can. If you have slightest of doubt, you can.
Right.
You already what? See this amazing wide opening of the wash. One more. One more. And see the mucosa is so healthy. Little bit edematous, which will settle down with the inflammation removed, with this ventilation drainage established. Wash one more. Ambe. With the fiber. Either. Hmm. Sometimes you might have some fungus within the folds of mucosa. See now, everything crystal clear now.
Yes, sir.
I was suspecting that fold of fungus, fungus within the fold of mucosa, which is out now. See the maxillary sinus, anterethmoids, see the frontal sinus, and until now we didn't bother about the anterethmoidal artery.
Okay. So intact bulla technique you did it.
Yeah, bulla since in this case,
Yeah.
when you have massive polyposis, bulla is always compromised.
Okay.
But since we know the anterethmoidal artery is far behind, now at this point,
Yes.
this is skull base blade, reverse blade. When you work in the vicinity of the anterethmoidal artery, never work in the extreme, work in the middle. Because all dangers of anterethmoidal artery are there if you work in the extreme. See the frontal now.
Yes, sir.
More. This is its model skull base.
Equator roof.
This is model skull base. Because of massive polyposis, the anatomy gets distorted, so you have to be ultra careful. More. See, that is frontal sinus, this is model skull base, this is middle turbinate. I have still kept the middle turbinate in place for its orientation.
Yeah. Will not address the concavulus part of the.
Yeah, we'll deal it, we'll do a partial resection at the end.
Okay.
Until now, we'll use this turbinate as a
Landmark.
landmark for orientation. See, my anterior model skull base and the frontal sinus work is over.
Yes, sir.
Now I will change to 0 degree again. Now the thing which is left behind is the sphenoid and the osteoethmoid. See now, to reorient you, this is with 0 degree. See, a lot of fungal disease. You have seen the sphenoid again full of fungus. Osteoethmoid is dangerous surgery if you are not oriented through cut. The part of the bular shelf which is left behind it. See our medial limit and lateral limit and the corridor. This is lamina.
Yes.
This is your middle turbinate. And this is your ground lamella, which I have opened a little bit. And see here, it was attached to the skull base. And this is all fungus. See the skull base much clearer now. That is skull base.
Yes.
Now, I don't want to carry out this post-ethmoidectomy at this point because I may accidentally enter the sphenoid sinus without knowing the landmark. So what I will do here simply, I will open up here into the ground lamella medially. Here is recess, sphenoid model recess with a lot of polyps into it.
Yes.
This is your
Pinadolostrum.
nasal septum here medially.
Yes.
This is your superior turbinate. This one. In between these two, remove the lowermost part of the superior turbinate. Go. See, this is the roof of maxilla. Use this as a line to stay in this line. See this maxilla? Refer to this line, maxilla. Go flush with the septum, and now I am in the sphenoid sinus. Can you see?
Yes, yes.
That's the sphenoid sinus with fungus. See the sphenoid sinus there? Once I have seen the sphenoid, I will come retrograde and finish up everything anterior to it. Everything anterior to the sphenoid ostium I can remove safely now. My optic now, carotid artery cannot come anterior to this point. Fungus. Full fungus. Again, reorient. This is the sphenoid ostium.
Yes.
Staying anterior to the ostium level, you can remove anything. Don't go behind, otherwise you can hit the optic nerve.
So now you're in posterior ethmoid.
Yes. After opening the sphenoid ostium, after ascertaining the sphenoid ostium, I have come retrograde to remove the postethmoid. If I start doing postethmoidectomy, I can be carried away into the sphenoid sinus without knowing it.
Yes.
See, now that's the sphenoid sinus level.
Yes.
I have removed everything anterior to it. Now, this is some fungus going behind. See this?
Yes. Yes.
Beyond the sphenoid sinus, anterior wall. This could be dangerous. See, that's the anterior wall of the sphenoid sinus. Now, this is the cell which is going further beyond. I have to be careful. See the fungus within?
Yes.
This could be onodi cell. See this?
Yes.
And in onodi situation, the optic nerve lies in the onodi rather than the sphenoid. See this? This sphenoid sinus? This
Yes.
is anterior wall, and this cell has gone far behind, beyond anterior wall. See this?
Yes.
So I have to through cut. Remove this party wall between these two cells. See this party wall?
Yes.
I can remove. See, I have removed this party wall. Widen the sphenoid now. See this party wall cell I have removed? I have made the sphenoid sinus a common cavity after removing that party wall with the postethmoidal cell. See now, widen the sphenoid sinus to the lateral limit. See, medially we know the intersphenoid septum is pushed far laterally. And this is all fungus now. See the big fungal material? Big fungal material in the sphenoid sinus. Sphenoid flush all around. This flush with the skull base superiorly, flush with the lateral wall laterally, flush with the inferior wall, not much inferiorly. You may damage the vessel supplying the nasal septum. Medially, yes, you can. See all around the sphenoid limit section. And now I can remove the fungus. See the cavity now coming in the shape.
Yes.
Now this is all fungus I am removing from the sphenoid sinus. Motor. See, all this is fungus. I have a power section. See, I can remove with a section. This is a very high power section in our theater. 1 horsepower. This is the lateral recess. See this?
Sir, now you're using the micro debrider
Suction.
section.
This is a very high power suction. See this?
Yes.
That's the beauty of high power suction. Now give me 40. I will just widen the lateral recess opening and then suck out, and we'll show you the sphenoid with a 70-degree from inside. Any 40 there. See, all sphenoid is empty. Everything here, lateral recess is still there, which I have not cleared yet. I will widen the anterior. See, I'm using red 40 to widen the interior wall of the lateral recess. See, just toward the interior wall, nowhere else. Can you see the fungal material inside?
Yes. Yes.
Now give me section view. That was the wash. Fungus from the lateral recess. Could you see this lateral recess?
Yes.
I will show you from inside. Let me flush into it first. That's the lateral recess. Here there's more fungus which has come out of lateral recess section. Now it looks clear. Now give me 70-degree to show you the sphenoid sinus from within. See all sinuses, everywhere the fungus is clear.
Yes.
Sphenoid, skull base, see the medial limit, lateral limit. 70-degree. And 70-degree will give you a intrasphenoidal tube. See this? Now 70-degree will show you. Yeah, I'll turn it upside down. See, that's a lateral recess. See the interior of the sphenoid sinus. Can you? This is lateral recess. This is lateral recess. Absolutely clear with thick.
Some
Hello.
is there. We have lost the picture.
I can't hear you. Hello. Hello.
Yes, sir. Your voice is audible to us.
Yeah. So now the final picture is just, you know, irrigation of the mucosa everywhere, all sinuses to remove anything left behind.
Hello, sir.
Yes, please.
Sir, can you show the sir position of anterior and posterior ethmoidal arteries now?
Post-ethmoidal artery, anterethmoidal artery are prominent. See, anterethmoidal place is here. I can see little prominence, but they are more prominent when the bone is more thinner. And the skull base bone is more thinner, more pneumatized, then they are more prominent because they run through the roof bone, ethmoidal roof bone. The bone is not very thin, they may not be appreciated. See, this is the oblique course of the anterethmoidal artery. Frontal is anterior and this is behind. This model course you can imagine few millimeters anterior to the optic nerve. But that is only if it's visible, if the post-eth model skull base is thin, eroded, then only you can see. Finally, what I'll do, because we had let a lot of polyps medial to the middle turbinate. See this middle turbinate? Looks stable. See this?
Yeah.
Still, because it has blocked the aeration of the olfactory recess. Can you see?
Yes.
Yes, yes.
So I will remove the lower part of the turbinate only. Upper part contains olfactory epithelium as well. For two reasons. Number one, to give good air access to the olfactory area now. Can you see?
Yes.
At the same time, give good access to the topical steroid in this region. These patients, many a time who present with olfactory loss, can be improved with this maneuver.
So, what is the topical steroid you use post-operative?
Budenoside. Budenoside respules, which pulmonologists use for nebulizing for asthma.
Okay.
We mix them in saline or ringer lactate.
So you ask them to do it every day.
Yeah, in the positions like we train them in lying head position or so
Yeah.
that they can penetrate, the solution can penetrate all areas effectively. See now? Now you can visualize all sinuses in your OPD, in the follow-up. Patient can deliver. See this, the topical steroids will go uninhibited now. See this?
Yes, sir.
No need of future scanning.
Yeah.
No need of, you can see in your OPD. If patient uses well, practically no need of future surgery as well if you treat the pathology properly with
Even nasal
comorbidities and all.
endoscopy is not required, sir, in this situation. You can
Pardon?
see quickly. Nasal endoscopy is also not required. Endoscopic picture is not required.
Yeah. You can see in your OPD only
Yes, sir.
with a 0-degree endoscope.
Yeah. So how long you are advising this steroid dosing?
It depends upon the pathology, underlying pathology.
Okay.
Like the allergic fungal sinusitis, we can't. You have to treat the underlying cause. Like here, how will you treat the underlying cause? Allergy, you can
You cannot treat.
give
No?
topical steroid, you can get allergic testing, immunotherapy. If the underlying cause is cured, yes, you can stop. You can, taper the doses, frequency according to the need under endoscopic serial visualization. If the mucosa remains good, you can keep tapering the dose and frequency.
Sir, how many rescues in one 500 ml of penicillin?
250 ml contains 0.5 milligram. See, this is the final picture. Everywhere
Right, sir.
mucosa looks intact. See the orbit, skull base, sphenoid sinus, maxillary sinus. This is what the full house face is. And this is where the frontal sinus is. See the frontal sinus with 0-degree.
Yes.
So wide opening of all paranasal sinuses. What all patient required in the post-op is the douching. If that is adequate, nothing is required to be done for this particular patient. We give oral steroid for a couple of days because this is AFRS. where the core treatment is steroid, and then topical steroid will get skin prick testing, immunotherapy if required, and regular follow-up. Improve the comorbidities, allergic rhinitis, if vitamin D deficiency, if any immunodeficiency, anything which can add on to the morbidity, which have a negative impact on the overall outcome, has to be improved. कैमरा ही लगाऊंगा ये तो बुला लेते हो बेटा
Ethmoidal polyp also, bilateral ethmoidal polyp, sir. Or
pardon
voice for ethmoidal polyp also post-operative conditions, you use the same dosing.
him see TRS child are simple.
Yeah.
TRS has many endotypes. So with your pre-operative
The
workup,
picture is not there on our screen. It is completely
we have removed. We are not showing on the opposite side.
okay.
और देखो इधर आ जाओ जल्दी. So now we'll move on to the next case because time is till 2:30 and we have 2 hours left. We have a huge case. JNA had a significant
Sir, the
extension.
picture is not there.
No.
Yeah, it's coming. So any questions regarding FES? Meantime. Hello. Hello. Any questions regarding sinus surgery meantime? किधर है 5 मिनट रेस्टोरेंट कैमरा वहां से होगा
Hello, Anil sir.
Hello.
Yeah, hi sir. Sir is starting a case, sir, in some time.
Yeah, it's okay. We are with you.
Can you give us the brief details of this person?
Okay.
What case you are studying up? What is the pre of finding? Just in brief.
We are not getting any picture.
Yeah, ma'am, camera is switched off.
Okay, okay,
Patient is getting induced and they're shifting the patient. So give us some time.
okay.
Hmm. Hello. Hello. Hello.
Yes, sir. We are with you, sir.
Hello.
Yes, sir. Good morning, sir. We can see you, sir.
Yeah. So we are starting in 5 minutes.
Right, sir.
So I'll be with CT scan in couple of minutes. CT scan and MRI. The
Yes, sir.
case is almost ready. So in couple of minutes we'll be online.
Right, sir. Thank you, sir.
Good. Hello.
Yes, sir.
Hello.
Yes, sir, we are with you. We can see the camera, the OT being prepared.
Are you getting some scans on screen?
No, not sir.
Let me know when you get the scans.
Right, sir.
So this patient is a young male, 14-year, with
We
a
are
history
getting
of
this scan. We are getting this scan.
history of intermittent bleeding and nasal obstruction. Young male, intermittent bleeding, nasal obstruction on endoscopy, some mass in the posterior part of the nose gives you suspicion of JNA. Then this patient was scanned somewhere else and referred here. So he was already having a MRI with him with classical clinical, history and signs of JNA with a mass behind. And you see on MRI. So we didn't feel like getting another MRI. We don't have in DVD, but since it was not extending too much to the skull base, so no need of further MRI. So what I'll share quickly if the case is ready. If you see from anterior to posterior, the anterior nasal cavities, all clear. Can you see?
Yeah.
But as you go behind, some mass is appearing. See now here. Look. See now? This
Yes, sir.
mass is appearing. Now come here. See now? This mass is there. This is going towards the infratemporal fossa. Can you see?
Right, sir.
Some vessel on the surface of the mass laterally, that is internal maxillary. And this mass is in continuity coming down in the nose. Can you see very clear?
Yes, sir.
This mass is rising up towards the sphenoid sinus. Can you see in the sphenoid sinus on this side?
Right, sir.
See this one picture is showing the entire mass in the infratemporal fossa, maxillary artery, far laterally on the surface, and lot of flow voids. See this black flow voids within the mass, showing
Yes.
vascularity. So the extension is in the nasal cavity, pterygopalatine fossa, infratemporal fossa, then going towards the sphenoid sinus. And this is the pterygoid process. This is the pterygoid process which is infiltrated. See the opposite pterygoid normal, this pterygoid is infiltrated. The below pterygoid fossa is clear, but the process is infiltrated. That's the sphenoid sinus, that's the lateral part. So now the carotids, the cavernous carotids, far away from the mass behind.
Yeah.
See this mass lesion in this sagittal plane. See in the sagittal plane, the carotids are far away from the mass. Can you see?
Yes, sir. Yes, sir.
So we didn't feel like getting another MRI on DVD. We didn't feel like.
The mass is just entering the sphenoid.
Yes, entering the sphenoid doesn't, get attached to any mucosa or the paranasal sinuses.
Yeah.
It doesn't get attached to the nasal floor. Takes attachment to the septum, turbinates, and the bone. So there's a classical of a JNA, clinically, radiologically, with a classical extension, preferential extension in the pterygopalatine fossa, infratemporal fossa, nasal cavity, and in the paranasal sinus behind in the sphenoid, but not extending to skull base. Once it doesn't extend to skull base, you can assume the preferential blood supply coming from the internal maxillary, which you can see there. So no, practically, CT angiogram is not so valuable, additionally valuable. Secondly, if there had been a lot of extension high up toward the skull base, definitely CT angiogram would tell us if vascularity coming from other vessels. Had this been extending to the skull base further and intracranial space, further MRI would help you giving relationship with the carotid and other structure, which is not needed here. So we didn't feel like getting another MRI done for this poor chap, and whatever information we get is not going to be, additionally helpful by any other MRI. So we are ready with the case. 2 minutes time, 2-3 minutes will be with you with endoscopic pictures. So our approach would be the modified tanker will go head on to the posterior wall of the maxilla, will open up the posterior wall, go behind the posterior wall, catch the maxillary, internal maxillary, and devascularize it first. Then we'll divide the medial wall of the maxilla into two parts, the medial and the lateral one. First, we'll remove the medial part, and then we'll bring in the, as the nasal space will be increased after removal of the medial part. We will bring in the lateral part in the nasal cavity and refill it. That will be the whole, plan. This is a classical, case of JNA, I would say.
So the CT scan is available?
Hmm?
So CT scan is available?
Plain CT scan. So the patient got somewhere done, but not very useful.
Okay.
CT scan cannot discriminate, non-tumorous from the tumorous pathologies, so that doesn't carry any value. And if been extending to the skull base, intracranial space somewhere more extensively towards the skull base, or laterally more, I would additionally get a CT angiogram and MRI and DVD with different more sequences. But this information is adequate looking at the extension of this tumor, which is very well excisable. So I didn't feel like getting another MRI for this poor side.
I would like to request Dr. Chinmay Sundarai sir to present memento as a expression of gratitude to Dr. Khageshwar Raut sir.
Hello. Hello.
Yes, sir.
Yeah, are you getting endoscopic picture, sir?
Yes, sir.
Now, look at this left nasal cavity. You have seen the MRI. See this mass lesion?
Yes, yes.
And in this particular case, bleeding management is the core, part of the surgery. And what I'm using?
Oblator.
Ablator on the surface. Maximum bleeding is on the surface. As the tumor grows, it becomes more and more necrotic from the center. Less and less blood supply in the center, and more towards the periphery. So always keep, coagulating the surface.
So, sir, what's one?
This is the new one the company has left with me to use to give my opinion, but most of the time I use Pro Size Max. This is the preferred one.
This is the hello one.
Pardon?
This is the new hello wand you are using, I think.
Don't know the name. They just gave me to give my opinion. I'm happy with the Pro Size Max. That's the best one I have come across, seen and done so many of such cases. See this? Just so whenever inadvertently, even if your instrument comes in contact with the surface, it is not going to bleed. Okay. Now, the next important thing is the exposure. 90% of the time is going to be invested in exposure. That's the axilla, roughly a centimeter below the axilla. This is the lateral wall or the medial wall of the maxilla. I am coagulating the mucoperiosteum. Even the terminate also, because ultimately it is going to be removed. I'm coagulating with the
Entire
coagulator.
mucosa, sir.
Pardon?
Entire mucosa you will be coagulating?
Yes, entire mucosa of the lateral wall. This inferior turbinate, which is a separate bone. Everything. See this, how bloodless the fluid is going to be. Hello?
Yes, sir.
What a tool. This mucosa is so richly vascularized otherwise. And now I am removing this with the ablator. I am ablating this.
We have lost picture.
What picture?
Yeah, little disturbance is going on.
See, this is the anterior wall here.
Yeah.
See the limit. And I am removing all this mucoperiosteum to expose this bone to be removed. See this? What a wonderful tool it is. This is not later when this is.
Sir,
We
we
are
have lost
having
the
little
picture.
disturbance. Can you just hold on? The
Sir,
lost
we lost the
picture.
picture.
If not populator went, I would say
Yeah,
this is
yeah,
like
yeah.
So this works like a magic wand.
Yes, sir.
What song? Pictures are clear. Fun correct. Just 5 minutes. Wait for a minute. We are changing the internal meditation. Can you see the anterior edge of the maxillary bone? Hello?
Yeah, hello, sir.
Can you see the anterior edge of the maxillary bone?
Yes, sir. Just 1 second, sir. They got disconnected. They are rejoining, sir.
सर्जरी में चलेगा ही कॉपलेटर यार पावर चेंज करना है
Arvind, now you can change your power, Arvind. Now they got disconnected. They are joining again. So meanwhile, you can correct.
अब भी हो रहा है क्या करता है यहाँ हम्म
Hello.
यस
Sir, we lost you for just 2 minutes because there was
यस
power failure here.
changing the power settings
Right, sir. We are with you. We can see the endoscope.
yeah are you getting the endoscopic picture
Yes,
now
Yes,
we are
yes,
getting
sir.
it. We are getting it.
okay
So you
now
have
it's
changed
fine.
the one.
Yeah now it's fine
I think now you are using process.
yes see now I have removed this mycoperiosteum of the lateral wall
Yes,
could you
sir.
see
Yes, sir.
this is the inferior turbinate which is a separate bone see this one
Yeah. So that's the anterior limit.
That's the inferior turbinate, which is a separate bone. Oblator. See, I remove the part of the terminate bone.
Yes, sir.
This now is the inferior meatus mucosa I am removing.
Sir, what's the
Till-
limit?
Till the floor.
Junction of lateral and floor.
Yes, till there.
And what's the anterior limit?
Anterior limit till piriform aperture. See this.
Okay.
Give rider. See now the lateral limit.
Yes, sir.
That's the anterior. And see if I elevate this mucoperiosteum laterally.
Yeah.
Anterolateral wall. See, these are the branches of the anterosuperior alveolar nerve, which are severed, but they have numerous interconnection, ultimately regenerate after a couple of weeks. It doesn't bother you much in long run. So that is the anterior bone. I can punch out this thin bone.
So, what's the instrument? Lux.
Just a lux, just to punch out the thin bone. Oblator. Okay. Under. Pata. So that's the anterolateral wall. You can go as much as you want, generally up to the infraorbital neurovascular bundle. If you want to go further for far lateral extensions, you can even transpose your V2 and go beyond. So now it is unlimited. See now, we have to enter into the maxillary sinus head on.
Okay.
And remove this, bone. The limit is the, yes. See this, I just show you by making this entry into the anterolateral wall. And see how superiorly we need to go. I will show you. Only cut section.
Is the normal drill you're using or anything specific?
This is a high-speed Medtronic drill.
Okay.
I am using right now 70,000 RPM. This is coarse diamond. And see the interior of the maxillary sinus now. See the interior of the maxillary sinus. See this?
Fine.
I will go and remove a little bit of the lateral wall. It has a reasonably good lateral extension as well. So I'll keep adequate lateral window. and the lower limit would be till floor. You have to flush till floor.
Means the floor of maxillary must hit the floor of nasal cavity.
Yes. See the level of the roof.
Yes, sir. So what is the
That's very
speed of the
important
birth?
to ascertain because you have to
Twenty.
cut your nasolacrimal duct flush to the roof. Ascertaining this level is very, very important.
Okay. So is it a diamond bar or a coarse diamond?
Coarse diamond. See, it cuts like butter. See the nasolacrimal duct just behind. See the duct just behind.
Yes.
Here, lower down, it opens to the valve of Hessner's.
Yes, sir.
See this, you have to remove this. See this
Yeah.
bony duct I am removing. Skeletonizing from all around.
Fine, sir.
Debrider. See the duct?
Yes, sir.
Now I will more and more clear it off and flush debrider till the flush till roof. See the duct? We have to cut it flush, otherwise it can get fibrosed. An overhanging duct below the orbital floor is likely to get fibro. This is uncinate process.
Yes, sir.
This is uncinate. Behind the nasolacrimal duct. See, you have to flush. You have a target. You have to flush till the posterior wall. Simple. Now, I am further uncovering the superior part. See this duct? The drill.
Yes, sir.
Drill. देखना अनुपम यार आवाज आ रही है तेरे को भी पकड़ना यार, पकड़े. See the duct?
Yes, sir.
Now, see this. At this point of place, see this flushing with the, I will cut it sharp. Where is the duct? See duct. Duct is here. Can you see?
Yes, sir.
See this. See
Yes,
the,
sir. Fine, sir.
that is the duct. So this will no longer overhang below the level of the divider.
Orbital floor.
Yes. बोल दे केस में. See, my nasolacrimal duct remains above the level of my dissection now. That's a part of the uncinate. See this?
Yes, sir.
You have to flush this medial wall till the posterior wall. See the posterior wall behind. This is posterior wall. Drill. And I will flush this medial wall till floor so that my instrumentation will be uninhibited. See this, all this has to be flushed. So when you work in the depth, your instrumentation will work uninhibited. Divider. See how the section बदलाई रखी. हटा हटा section लगा. See how the visualization has improved.
Yes, sir.
वाले यार 50 बार के दिन.
So this mucosa you're not going to ablate?
Yes, I will. I will. I will further improve my field first.
Yes, sir.
All mucosal edges which are bleeding. That's remnant of the inferior turbinate. It keeps on bleeding because the vessel comes from behind.
Yes,
The
sir.
main vessel to the turbinate.
Inferior terminal.
Yeah. This is the middle turbinate. And see the tumor attached to it. See this tumor attached to it.
Yes, sir. Yes, sir. Good.
That's the tumor. Now more tumor getting exposed,
Yeah.
more surface coagulation. See this?
Yes, sir. We're almost approaching the neck of the tumor.
Yes, that's the neck level where we are going to divide also.
Yes, sir.
Now, this is the pterygopalatine fossa region medially, and this laterally is the infratemporal fossa. Pterygopalatine fossa is a narrow space which is bounded behind by the pterygoid process. Pterygoid process has medial and lateral plates. So, pterygopalatine fossa lateral limit is lateral pterygoid plate.
Yes, sir.
Lateral to that is the infratemporal. See now the tumor coming from behind. See this?
Yes, sir. Yes, sir.
This pushes the bone, makes the bone thin,
The bone is almost thinned out.
thinned out because of the tumor pressure. More it is coming, pushing from behind, more it is thinned out.
Yes, sir.
See, all mucosa has been removed. Now this bone has to go and reach out to the periosteum.
Yes, sir.
Obliterate them. See the thin bone removed.
Yes, sir.
That's the pterygopalatine. Pterygopalatine fossa, periosteum behind.
Yes.
See the bone over the greater palatine canal removed.
Yes, yes. Mhm.
This is pterygopalatine fossa, periosteum now.
Yes, sir.
Periosteum.
Yeah.
See the periosteum exposed?
You know, a small portion right here.
This is just expanding your window a little more. Oblator.
The IMAX is displaced lateral.
Distance for?
So the IMAX was displaced laterally as per the MRI.
Yeah. So that is the lateral limit.
Yeah.
Then it comes horizontally inside. This is inferior orbital fissure above.
You can see, so. Yeah.
Yes, this one. See, this is the V2 coming.
Yes, yes.
IMAX gives lot of branches to all surrounding foraminas.
What's the punch you are using, sir?
The Carrison punch.
Straight or curve?
Straight one. There's a very stout punch. Very, I would say, powerful one I have. Because I use
Remove the
very often for the skull base bone.
remove a portion of the pterygoid plate, I think.
Now, this is a very, very powerful punch I have.
Size, sir? 3.
Pardon?
What is the size of the punch?
4 mm. From Karl Stores. The same punch I've been using almost for more than 7 years from now. See, all bone medial to above the tumor. See this?
Right, sir.
This tumor is one component. Since it has occupied different areas, it looks multilobulated, but this is one component. See the tumor.
Yes, yes.
That's the tumor surface exposed. See the multiple lobulations of the tumor.
Yes, sir.
See now the complete tumor in mediolateral aspect. Now we have to focus for the IMAX. And devascularize this. See, this is the periosteum.
Yes,
The
sir.
beauty is, more the tumor pushes from behind, more the vessel is pushed over it. Because vessel runs over the surface. Can you see the vessel?
Yes, sir. Very clearly.
So later. ये branch है. It gave branch inferiorly as posterior superior alveolar now. It is grand medially as a greater vessel, as a greater superficial alveolar artery. See this looks like
Yeah, yeah.
posterior superior alveolar now, vessel. See the main trunk of the vessel. Can you see?
Yes, sir. Yes.
Can you see the vessel over it?
Yes, sir. Clearly.
थोड़ा निकालो निकालो हाँ अब पकड़ 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 So first of all, I will इधर लगा दो। जल्दी से जल्दी vessel निकली no 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 torn one of the branch torn
Yeah.
मोटा ले सेक्शन मोटा ले see one of the branch here torn that was could you see इधर I placed two clips over it. And divided. Could you see the vessel divided?
Yes, sir. Yes. What is the size of luggage clip you use?
200. That is 200. So one part is see the vessel, main vessel. See the lumen.
Yes.
So this I will leave for a while. See the two clips. Can you?
Yes, sir.
Now I will leave it like this for a while. And I will more and more expose all around the tumor. See this. I will go above the tumor to dissect in the paranasal sinuses, go medial to it, go behind, expose from all over, then divide and then remove both the parts. Say this, terminate.
Middle turbinate.
This tumor preferentially takes attachment on the terminates, on the septum, not on the mucosa of the paranasal sinuses or floor of the nose. See the tumor below?
Yes, sir.
This is paranasal sinuses. I will define my lamina here. Okay. See, all these are paranasal sinuses which I have to dissect. quickly. This work you can do quick. There's nothing. See the postethmoids.
Yes, sir.
This is my lateral limit and lamina. See the tumor below.
Yes, sir.
Expose superiorly by removing bone over it, medially behind, everywhere. This ethmoid sinuses. Tumor is here. The tumor is below. See
Yes, sir.
this? This is tumor in the sphenoid sinus. See this tumor?
Yes, sir. Now
See,
only
all
the
paranasal sinuses are okay above.
yeah.
Tumor is here now, coagulator. So we
Now
have
I
exposed
think the
superiorly.
septal only septum attachment is left.
Yes, yes. Septal and nasopharyngeal roof, both.
Yes.
This enters the sphenoid sinus through the floor or the pterygoid process, but never through the ostium. See now, this is the this is maxillary sphenoid sinus.
Right, sir.
This is tumor surface I am coagulating. More and more tumor coming into view, keep coagulating. See this surface everywhere. खोल यार. खोल. See now the tumor is behaving much better now.
Yes, much clear.
We are devascularizing. We have clamped the main vessel. We have, coagulated on the surface everywhere. Now this is the
Septum.
septum. दूसरी मंगा बैठ. See, I have removed this mucoperiosteum. And see the tumor within the sphenoid. See where it has entered through the defect in
Yes.
the floor.
Yes, sir.
See the defect in the floor. Similarly, we'll pull from there only. See, tumor has entered from here.
Yes, sir.
So we will widen this bottleneck. See this bottleneck. So I can push the tumor down easily. This tumor has to be pushed down like this. Okay?
Yes, sir.
This is the tumor in the pterygoid process. See this. Yeah. That's the pterygoid component of the tumor. See this?
Yes, sir.
See the sphenoid component, it never takes attachment within the sinus. Now we'll go medial to it further and behind. I'll just make this posterior septotomy from the anterior edge of the tumor. I hope you are oriented. Hello? Hello? Is everybody oriented? Now the posteriors have taught me to go to the opposite side. Hello, am I audible? Audio visual? Hello? No problem.
Hello, sir. Sir, they got disconnected. Their power is gone. So just reconnecting, sir, in 2 minutes.
Is the picture also not going?
No, picture is going, sir. Now they connected again, sir. I hope so. Anil, sir, can you hear us?
Yes.
Yes, sir. Thank you so much, sir. So you got disconnected. Now sir is calling you, sir.
Hello?
Yes, sir.
So I am doing this posteriors have taught me to go to the opposite side. See this?
Okay.
Can you see the tumor in the nasopharynx?
Yes, sir.
See the nasopharyngeal roof which I am disconnecting to the opposite side to block off any blood supply coming from the opposite side. See that?
Yes, sir. Yes, sir. Clearly, sir.
See this? That's the adenoid surface, that's the Eustachian tube, and that's the periosteum which I am removing. See now the opposite side is completely disconnected.
Yes, sir.
That's the tumor.
We just have to take care of the estrogen tube.
Just here.
We just have to take care of the estrogen tube opening.
That's the Eustachian tube.
Yeah.
Now again. So we have exposed the tumor from all around. See this now. Now what I will do, I will disconnect this medial portion of the tumor from the lateral one. See now?
Yes, sir.
Such a well-behaved tumor.
Silently going into the foraminus.
Yes. Now this is my bottleneck.
Right, sir.
So इसको यूं करना है.
Yes.
See, that's the pterygoid plate. See, here I am going to divide at this level. See this?
Yes, sir.
Bipolar. See, that is the bottleneck.
Right, sir.
I will catch this bottleneck once with the bipolar also. इधर है. See this? See this? खत्म करना है यार. See now the bottleneck? Now
Yes, sir.
I will easily, cut with the cobbler. Like butter. See the medial and lateral components separately?
Yes, yes. Clearly, sir.
This is lateral. See this completely.
Right, sir.
And this is medial. Could you see? Very clear?
Very clear, sir.
So this is plant division. Now we will bring this medial component down and get rid of this. See this? Easily came out of the sphenoid.
Yes, sir.
There is a small attachment in the sphenoidal roof. I will in a minute's time get rid of this. See the sphenoidal attachment, roof attachment.
Yes, yes.
Free. So now it is free. See this?
Yes.
Absolutely free.
So it's free to go now.
This is not a very big component, so I can push it down into the oral cavity, oropharynx, and pull it through the oral cavity. Or since it is devascularized, deflated now, I can pull from here also. See this?
Yes, sir.
You can pull from here also. See this?
Yes, sir.
So this was a planned division and the entire medial component is out.
Okay.
See, such a well-behaved tumor. If you devascularize properly, follow the principles of devascularization. See this sphenoid sinus above?
Yeah.
See everything? So clear. See no attachment in the sphenoid.
No attachments.
Attachment on the adenoid surface as well. See, this is adenoid surface below. There is
Yes.
no attachment there. It was attached onto the periosteum, which we have
Remove.
coagulated and cut. All clear? Now
Yes,
the
sir.
lateral component is left. And believe me, once you remove this removal of the lateral component is a cakewalk. Rani Jara. Now the removal of the lateral component. See this big lateral component?
Yes, sir.
So now this was a planned division. Now we will pull it, the lateral one, and dissect and remove it. See, this is the vessel over it.
Yes, sir.
That's the vessel. See, this was the branch this was the branch going below this one. See the multilobulated tumor.
Yes, sir.
See, the tumor is coming Pull. A gentle pull is the key and dissection. See this?
Yes, sir. Yes, sir.
Cobbleter I am using as a dissector.
The pad plane is clearly visible.
Yeah. I told you it's a cakewalk. See the traction and counter traction. That's it. Keep advancing your instrument to hold it. Traction. See, this was all infratemporal fossa component
Yes, sir.
which we could clear. Idhar pakad, rukna, छोड़ना मत. Can you see?
Yes,
And
sir.
vessel is over the surface which I have dissected off. See that?
Yes, yes.
See the vessel there?
Yes, sir. With the Liga clip.
See, this tumor doesn't infiltrate. This goes by pushing margins. See this? All tumor
Out, sir.
coming out. That's a lateral component.
Very nice dissection, sir. Thank you, sir, so much for a nice demonstration.
You all can do it. Simple. This is reproducible. A simplest version, anybody can do it. Now we'll check the pterygoid process. Then a call later then. Some pterygoid venous oozing is expected. यूं रखना यूं. See this pterygoid fossa,
Yes, sir.
infratemporal fossa, this pterygoid. See, tumor came encapsulated. So there is no question of tumor leaving behind. This is all venous oozing. Give me a. That was the pterygoid process. See the pterygoid process.
Yes, sir.
And the tumor came out intact, so there is no question, but I will definitely assess because even if you leave a micro tumor, it can regrow. I will leave the pterygoid bone absolutely flushed. See the pterygoid bone?
Sir. Are you going to ablate it or drill it?
On doubt. See this so flush normal bone.
Yes, sir.
There's no point. Drill. वो देना. See the sphenoid floor completely.
Yes, sir. Sir, is the Vidian exposed here?
Yes.
I think so.
Yeah.
Yes, sir.
So
Yes,
Median canal is almost involved in such tumors. See this pterygoid process?
Yes, sir.
That's a lateral recess. Hatama. That's a lateral recess. See that?
Of sphenoid.
Yes. Here is the lateral recess here. See that?
Yes. Yes, sir.
Now I'll finally flush this pterygoid bone here. This is not the coarse diamond, this is the diamond bar.
Okay, sir.
See the lateral recess much better?
Yes, sir.
And see the thick pterygoid bone. Good pterygoid process with no tumor in it. Can you see?
Yes, sir.
Absolutely normal, healthy pterygoid process. See that everywhere?
Yes, yes. Very clear.
So this is all about this tumor. Give me a wash. For any further extensions, this approach is basic one. Tumor going to the cavernous sinus, superior orbital fissure, parapharyngeal. From here onwards, take 1 minute for every extension. This is the basic approach. Yes, sir, this is like that. Absolutely fine. See, no bleeding. For this patient, we didn't transfuse anything. No embolization, no transfusion. Can you see?
Yes, sir.
Public. Hardly any blood loss.
What is the packing you will go with this patient?
Just marrows. Some gauze and marrow cell packing for a day or two
Yes, sir.
on prophylactic basis. That's it. So my assistant will do it.
Fine, sir.
Disconnect. So thank you very much.
Thank you. Thank you
Any
so much.
questions we can take before we call it a day?
Yeah.
Please.
Sir, one
Anupam.
query.
Anupam.
Hello.
Hello. Yes.
Sir, the size of Liga clip you used is 200.
Yes.
If the applicator is same or you have to change the applicator for
Same.
100 and 200?
Carl stores.
The same applicator can be used for 100 and 200?
Yeah.
Sir, do you use Surgicel in all cases?
Yeah, towards the infratemporal fossa surface because there are a lot of, oozers
Right, sir.
from the pterygoid plexus, venous bleeding that is frustrating. You don't need to fiddle into it.
Okay.
Sir. Thank you so much, sir. It was a fantastic demonstration.
Hey, boss.
And it was quite quick.
Thank you. Thanks
That's
to the
quite
organizing team for this midterm CME. And big thanks to the Dr. Anil Kumar Das for, who was constantly in touch and wanted to make it better and better. And all attendees and everybody for bearing with me. Thank you so much.
Thank you very much, sir, for giving us valuable time of your practice. You have devoted some time and we learn a great dissection of the angioplasty, particularly the medial dissection and lateral dissection is very good. It's a learning for every one of us. We are all learning this from your skill. I am proud of you, sir, being a PGI alumni. I am very much proud of you that I am learning these things from my teacher. Thank you, sir.
Thank you. Thank you so much. Thank you, everybody. Good day.